I'm Rachel Salit. I'm one of the bone marrow transplants here at Fred Hutch. I also have an appointment at UW. My primary focus is improving transplantation for patients with myeloproliferative disease. So hopefully this will be a good overview in terms of transplants. And if you have any questions afterwards, um, I'm happy to answer. So I think we all show this slide because this is what it was like before we had all these great drugs that Anna just talked about. And we've made such headway in the last 10 years that now we look at this and say, oh my gosh, look at what people used to look like when they had these diseases. So by the end of this talk, I'm hoping you'll understand which MPN patients are stem cell transplant candidates and what transplant risk factors are unique to the patients with MPNs, and then the role of these JAK inhibitors that Anna just talked about in improving outcomes of stem cell transplant. So how they can be used together to give patients better outcomes. So this is the classification for MPNs, and I think this was overviewed well before. And these are the three that I'm going to talk about in this segment: the polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Um, Essentially, the only patients we transplant are either patients who have primary myelofibrosis or who have transformed from PV or ET to secondary myelofibrosis. So as Anna said, it's very rare to transplant patients who have ET or PV. So myelofibrosis, as we talked about, is a clonal stem cell disorder. It can be primary or secondary. We think that the inflammation from these drivers, the JAK2 or CALR, MPL, results in these chemicals called cytokines, which results in an inflammation. And the fibrosis is like a scarring that goes to heal this inflammation. If the inflammation and the scarring gets severe, it can actually form into extra bone. So we see when we do bone density scans, people look very dense in their bones. The symptoms these patients have are fevers, night sweats, weight loss, and sometimes bone pain. And sometimes people have very long courses that are stable, and sometimes the kinetics of the disease just are more rapid. And some of this is based on the mutations that Dr. Halpern talked about. As far as what we're looking for in terms of, is the disease now severe? And I'll go over the scales, but is the marrow failing? So are patients starting to get bleeding? Are they starting to get low blood counts? Are they needing transfusions? Do we see blast cells that show that we are in a pre-leukemia rather than a chronic phase? And are we starting to see symptoms from having a large spleen, which may then lead into having a large liver? So transplant right now is the only cure for myelofibrosis. The other treatments are more for symptomatic, some may be disease modifying, but right now not curative. When I meet with patients, I would say the decision's never straightforward, and every patient has their own reasons to proceed with a transplant or not. So we answer these difficult questions, and I would say it's all shared decision making. So how old is the patient? What is their life goals? What's their disease risk, and what scoring system should we use now that we have so many? What are our donor options? Do they have siblings we can use? Do they have a good search in our donor registry? And then how are they responding to these other therapies that they're already getting? So are they feeling great now? Does it look like their counts have improved, or are they progressing? And then, every patient has a different opinion, whether they're 30 or 75, about how they want to spend their time in their life and what their goals are for longevity. So which patients are stem cell transplant candidates? And so I'm going to use this patient example, and this is actually one of Dr. Halpern's patients. I don't know if she'll recognize who this is, but this was the patient I saw, a 69-year-old female, primary myelofibrosis, who came to me through Dr. Halpern for a consult. And she has a low white count, a low hemoglobin, low platelets, and some blasts already in her peripheral blood. And I think Dr. Halpern sent her because she already had 2 to 3+ fibrosis, and 3+ is the highest score. And she had these pre-leukemia cells in her bone marrow. And then she had, oh, here we go. And then she had complex cytogenetics, meaning her chromosomes, there were several that were abnormal. And then on this next generation sequencing, which is the mutations, she had JAK2, but also an ASXL1, and she was having symptoms at least 3 days a week. And so we looked at these prognostic scoring systems. So I know there's a couple of you that have myelofibrosis in the room and may have discussed these scoring systems. We started out with this DIPSS that had these 5, and then that went to the DIPSS plus, and the D stands for dynamic. So every time we look at the score in time, you could have a change in prognosis. I would say over the last several years, we're tending more to use the MIPSS 70 or the MIPSS 70 plus, and there's a 2.0 version. And these scores include more variables. So in addition to the age and the symptoms and the blood counts, they also include the fibrosis grade and the mutations. And so based on the score of low, intermediate, and high, it gives you what is the median survival. And I would say in general, we use a median survival of greater than 5 or less than 5 to decide whether someone warrants a transplant candidate. And I'll show a curve that shows that. Right now, Medicare is basing their decision to transplant on the DIPSS or DIPSS plus scores. And so you have to have an intermediate 2 or high classification in order to have your transplant covered by Medicare. And this is something that the registry and Medicare are doing together to see if patients that are greater than 55 benefit from transplant for myelofibrosis. Okay, so here we have our patient, our 69-year-old female, and we calculate her score. And this is one of my colleagues found this pmfscorecalculator.com, and it will tell you all the scores at once. And so when we put her variables into the scoring system, she had high by DIPSS, high by DIPSS plus, and then high by the MIPSS 70 and high by the MIPS 70 plus version 2. So we see that her survival on all of these measures is less than 5 years. So this was sort of our dogma study that determined that patients with the intermediate 2 or higher should go to transplant. And this is what Medicare is using. It was published back in 2015, so a little older now. And we did have a study here where we looked at the DIPSS plus and saw similar answers. So you can see here if a patient's low risk, the transplanted group, which is the dark line, had a worse prognosis than the non-transplanted group. So we say, okay, low risk should not get transplanted. I would say intermediate 1 is a little bit more controversial, but you can see the lines don't cross until, years down the line. And so people say, okay, if you're intermediate 1, your benefit from transplant wouldn't come until much later. So maybe you would say a 30-year-old patient might benefit, but maybe a 70-year-old patient wouldn't. And then the intermediate 2 and high risk groups, the transplanted group lived longer than the non-transplanted group. And so those are the groups we say to transplant. So if you go to the National Marrow Donor website, which is the Be the Match and finding donors, and it'll give you any information you want about transplant. We just updated these this past year for the MIPSS 70 plus, and said that transplant is recommended upfront for patients with intermediate 2 and high risk on the DIPSS and DIPSS plus, and then high risk on the MIPSS 70. But we recommended that high resolution typing, so looking for a donor and referral to a consult, was recommended for patients in all of these categories. And so, any of your doctors that look on this website now would say, okay, if you have a young age, if you have high risk features like one of these high risk mutations, if you're failing your therapy, then it would be warranted to send you to a transplant center to get a consultation and get an opinion, and potentially get a typing going. So in the event you changed your disease course, there would be a donor that could be available. And again, patients with ET and PV are rarely recommended for transplant unless they have transformed to myelofibrosis or are very refractory to therapy. Okay, so back to our patient. So this woman has advanced age 69. So I have a lot of patients say, at what age do I age out? And I would say, we don't age out patients anymore. So we transplant patients really, I think this year, 78 was the oldest patient that I transplanted. So if someone's healthy and well, they're a transplant candidate. She has high risk of transformation to leukemia based on some of these findings. So ASXL1 makes her at a high risk for transformation to leukemia. There's many other mutations and combinations of mutations that would be true for. We look at patients' comorbidities. So how healthy are they? Do they have a history of heart disease, diabetes? Have they had a stroke? Do they have arrhythmias? Do they have infections that are uncontrolled? We also look at their performance status, meaning, are they able to do their regular activities? Are they fit and healthy? Are they exercising? Or are they laying in bed most of the day? And then we look at what their donors are. So do they have a sibling donor? Do they have a perfectly matched 10 of 10 donor? Or do they have only a half matched donor, which I shouldn't say it that way because I know at some centers, half matched donors are becoming more and more in favor for this disease. So this was actually in the ASH presentation book, and I really like this figure because it says, how do we weigh these factors? And so, if a patient has advanced age, so I would say maybe over 65, we would call advanced age because in these DIPSS scoring systems, 65 or older is considered advanced. Is their performance status good? Do they have any comorbidities we wouldn't look at? So yes, we would do therapy first. No, we would go to transplant right away. Do they have severe disease complications like a huge liver, spleen, heart effects? Do they have one of those mutations that have high risk for leukemic transformation? So you can look, if you go back, you can say, okay, these are what I highlighted in here: the advanced age, the high risk of leukemic transformation, the comorbidities, the not well matched donor. And you can see how complicated it is to make the decision, would this person be a good transplant candidate and should we send her along? So what are the transplant factors unique to patient with MPNs that we wouldn't see necessarily in patient with leukemia or lymphoma or aplastic anemia? So the bone marrow is fibrotic. So patients have an increased risk of graft failure. I think we've been lucky at our center that we have not had very many patients have graft failure. And I think that's due to our high intense conditioning regimens, which I'll talk about. But having a bone marrow that's fibrosis, I liken to having a weedy garden. So you're trying to grow flowers and pour soil in a weedy garden, and you're trying to get these stem cells to grow. So it's more difficult than when you have a healthy marrow. You also have many patients that have a big spleen. And so you can lose some of these cells to the spleen. When we give the cells, we want them to go into the bone marrow. And if they land in the spleen, we don't have enough cells to engraft the marrow. The symptoms can create the decreased performance status, which is, I think, what Dr. Halpern talked a little bit about. And the liver and heart dysfunction are also unique to this disease due to the fact that disease can happen even outside the bone marrow. So you can get this inflammation, you can get the backup into the spleen and the liver, and that can also affect how the blood circulates in the heart and into the lungs, and cause issues that way. Also, because of the inflammation, you can have a higher risk of something called graft versus host disease, which I'll talk about. So the JAK inhibitors that Dr. Halpern went through have had a profound effect on the outcomes of transplant because it affects these unique features of myelofibrosis as a disease. So she talked about how it decreases the spleen size. So by decreasing the spleen size, we've been able to decrease graft failure and poor graft function, also decreasing post-transplant relapse in patients that have smaller spleens. It can decrease portal hypertension, which means the liver gets congested. So the JAK inhibitors have been shown to actually make the blood move better through the liver and relax liver cells, decreasing the pressure in the liver's vessels, which when you have a healthy liver, you respond better to the drugs and better to the transplant itself. It also can decrease pressure in the lung arteries. So it decreases the thickening of the walls of the lung arteries, making the blood flow better. It also can make the lung arteries relax, making the blood flow better, and then decrease in the symptoms. So it has had one of the profound effects the JAK inhibitors have had, even though they're not curative, is making people much better transplant candidates. So this is the total symptom score. I don't know if this is that relevant, but the JAK inhibitors, Anna talked about, decrease the total symptom score. So when we say that the symptoms improve, it can be anything from abdominal pain, inactivity, sleeping, night sweats, itching, bone pain. So all of those things make people better transplant candidates. And so these are the 4 that she showed. And if you look in here, the symptom score went down 50% with the ruxolitinib, 50%, or I guess 35% in the fedratinib, 25% with the pacritinib, and 25% with the momelotinib. So it's improved the patient's symptoms and therefore their transplant potential. So what are the role of the JAK inhibitors in improving stem cell transplant outcomes, and what data do we have? And this is what I've spent most of my last 12 years here working on, is now that we have all these drugs approved, how can people do better with transplant? So you're on a JAK inhibitor and you say to your doctor, okay, I feel great, which is most of the patients do within, 8 to 12 weeks of starting. Should I even get a transplant now? Because I don't feel like I need one anymore. And so there's 3 times we could consider transplanting a patient with on a JAK inhibitor. One is when they have improvement on the JAK inhibitor. One is that they become intolerant to the JAK inhibitor or they lose their response. Or the third one is wait till they progress to leukemia because they're doing so great on the JAK inhibitor. And so there was a study that looked at these 3 groups, and basically the answer is patients should be transplanted when they're still responding to the JAK inhibitor, which is sort of a hard pill to swallow because I think patients who've been feeling crummy for a long time start their JAK inhibitors and feel better, and they want to wait until they don't feel better anymore to get their transplant. And it's very hard to predict, and that's one line of research. I don't think we've been extremely successful in answering the question of how long is each individual patient going to respond. So I get asked that a lot, like, how long do you think I'll respond? So the average is 3 years, but some people respond 1 year, some people respond 10 years. And at some point, we need to make a decision. Should we take advantage of this response and go for the transplant? So these are all the studies that have looked at whether JAK inhibitors improve transplant outcomes. And we're around right here. And so I guess there's not a lot of comparison in terms of what things look like before, but I'll show that on my next slide. So just to know, there's a lot of research going on in this area. And this was our first study that looked at giving JAK inhibitors purposely before the stem cell transplant. So if you looked at that diagram that I presented from the ASH website book, it said, okay, if you need a transplant, go straight to transplant. And so that was the idea, and that's what we always did here. And then these drugs became available. So we thought, should we use these drugs in a purposeful way to try to get people better responses with their transplant? And so we would give the ruxolitinib or Jakafi for at least 8 weeks to try to improve patients' spleen and their symptoms. The average on the study was 7 months. Then, if they met transplant criteria, we'd look for a donor. So they could have a sibling match donor, an unrelated donor, or a cord blood donor. And then, based on their age and how healthy we'd choose what type of chemotherapy type conditioning to give them. Anyone who gets a stem cell transplant needs therapy to empty their bone marrow from the bad cells and make room for the good cells. And so with the transplant, we're both trying to give you new healthy stem cells, but also a donor's new immune system that will recognize any leftover bad cells and get rid of them. So we're giving you two things, new stem cells and a new immune system. And then patients received graft versus host disease prevention to prevent those immune cells from attacking their organs and causing trouble. So in that study, we had 61 patients. And I'll just point out here that our 2-year survival was around 80%. And our relapse rate was 8.3%. And the risk of dying from transplant was about 13%. So these transplant procedures aren't to be taken lightly. There are people that die from the transplant procedure, and that's why people aren't necessarily in a rush to go into it. But if you see that the survival is around 80% and your risk with the scoring system is less than that, then it may encourage you to proceed with transplant. I also wanted to point out, and I don't expect you to remember this, is that the acute graft versus host disease rate was 74%, meaning that complication of the immune system attacking the patient in other ways than just attacking their myelofibrosis. The chronic graft versus host disease rate was 60%. And so this is data from our study in patients before the ruxolitinib was available. And this is data from that study I just showed you. So you can see before the ruxolitinib, we had patients with low risk had very good outcomes. But once you had intermediate 2 or high risk, your outcomes went down. In the current study, the high intermediate 2 group still had about 70% survival. Okay, so we're back to our patient now. She only has half matched donors. So I just wanted to say no fear. So if you're a patient that needs a transplant and does not have a 10 of 10 donor or a sibling donor, we do have a study open now where we're looking at half match donors. And there was a study done at Johns Hopkins looking at half match donors. There are other centers looking at half match donors for patients with myelofibrosis. We've enrolled 8 patients on this study so far. And we just expanded to another 10 patients. So in the meantime, the Jakafi was also approved for the treatment, or ruxolitinib, approved for acute and chronic graft versus host disease treatment. So we knew it's effective for myelofibrosis, but is it also effective for other types of inflammatory diseases? And so the company said, let's look at it in these transplant complications. And so the first studies they did, REACH 1 and 2, looked at acute and chronic graft versus host disease and showed that you could drop acute and chronic graft versus host disease by a substantial percent. So 55 and 62%. And the response rate was 73%. They also looked at the treatment in chronic graft versus host disease and showed that you could also improve chronic graft versus host disease in 50% of patients compared to 30% of the best available therapy. So based on that, our second study, which is currently ongoing, not only gives the ruxolitinib for 8 weeks before, but we continue it until about 1 year after. So a patient gets the transplant, same, we choose a matched sibling and unrelated or a cord blood donor. So far, we've only done sibling and unrelated on this protocol. We decide what type of chemotherapy they would receive. And instead of just getting these 2 drugs for graft versus host disease prevention, they get 3 drugs. So this is our study. The patients get started on their Jakafi. They continue it for at least 8 weeks. We measure their spleen. We look at their symptoms, and then they must come and meet transplant eligibility. We taper the Jakafi over 1 to 2 weeks into a lower dose, and then continue until about 9 to 12 months. Anyone over 18 with a diagnosis of primary or secondary myelofibrosis can enroll, and they have to have only intermediate 1, 2, or high risk disease and good lung, heart, kidney, and liver function, and a low comorbidity score. We allow these donors. And so far, these are our results on this study. So we've enrolled, this is the first 25 patients results. We've enrolled 33 of 45 patients now. Most of the patients have had unrelated donors in this study, so 23 out of the 25. We've had no graft failures that were primary graft failures. One is a secondary graft failure, meaning the immune system cells started to go down about a year after the transplant, and he needed a booster of immune cells. But look at the acute and chronic graft versus host disease rate. So now we're down to 28% in the low grade graft versus host disease and 16% in the high grade. In the chronic graft versus host disease has gone down from 50% to 12%. So it's sometimes people say, oh, are these JAK inhibitors jack of all trades? And I think for myelofibrosis and some of these other diseases, they're good for both the disease treatment and the transplant treatment. So far, we've only, in the first 25 patients, we've only had 1 death from transplant-related complications and 1 relapse. And so it's really improved our outcomes for patients. And these are the studies right now using the JAK inhibitors before and after transplant. So we're getting ready to publish our first 25 patients of data. There's 3 other centers who have also done small studies looking at this in the myelofibrosis population. So in summary, I don't know how I am on time. So who is a transplant candidate? So a DIPSS or DIPSS plus intermediate or high risk, or MIPSS 70 high risk. There's no age cutoff, and we have protocols here and other centers do for all donor types. So there's not really, I don't have a donor anymore. What are the transplant risk factors unique to patients with MPNs? The marrow fibrosis, making it harder to engraft, making us need to use that chemotherapy to get the cells in. The splenomegaly, which we try to reduce to make sure that the cells go in the marrow. Liver and heart issues, which is another reason to transplant earlier before patients develop these liver and heart issues. And then the increased risk of graft versus host disease we see in this inflammatory type disease. And what are the roles of the JAK inhibitors in improving the stem cell transplant? They're effective in decreasing symptoms in splenomegaly. They may have activity in fibrosis in the marrow, but also in other organs. Using the JAK inhibitors in GVHD prevention is under study, but it seems to be very promising. And doing the transplant while still responding to the JAK inhibitor likely leads to better outcomes. And thank you to everybody for inviting me today.